Hello, my name is Marge Benham-Hutchins, and I am an associate professor and interim chair of the Department of Biobehavioral Health Science here at the College of Nursing at TAMUCC. I am going to be giving a short overview of health informatics. I encourage you to review the materials I've provided by James Turley, an interview with him, and it will help you understand why I moved from calling this nursing informatics to health informatics. This presentation has four main objectives. The first one is for us to explore a little bit about the historical development of informatics as a discipline, profession, and specialty. And as I mentioned earlier, I'm calling this health informatics because I'm looking at it from a health perspective, but with a nursing lens. Another important objective is to examine the data to wisdom model. This is a theoretical model that is used in health informatics and in nursing, and it stands for data, information, knowledge, and wisdom. We will also be exploring health information technology systems, interoperability between systems, and standards. And then something very important to nursing is that we're going to identify how health informatics supports safe, efficient, quality patient care. Many of you will recognize this photograph as being Florence Nightingale. Florence Nightingale used data and collected data to change the way patients were cared for. In this particular case, on the far right is a graph she developed to show the causes of mortality in one of the armies during the Crimean War. She also is really well known for her statistics, and a lot of people don't realize that about her. So in some ways, we could look at her as one of the first nursing informatics specialists. Florence Nightingale collected her information on paper, and as a society, we continue to collect information the same way and keep medical records where each patient would have an individual file. As medicine got more complex, care got more complex, the number of medications, interactions, this became really fraught with error, where there were lots and lots of medical errors based on either the lack of information, interaction between drugs. In the upper left-hand corner, you'll see that somebody would have had to be able to read that, and there were a lot of errors for medication administration based on physicians' orders that you would not be able to read. X-ray films still are, but in many cases are now moving totally to digital format so they can be exchanged. It used to be you had one copy of a particular test and that was it. They maybe could make a copy, but now we have digital X-ray machines, which has done away with a lot of the different caustic developing materials and fluids. And so a lot of ways moving to electronic records has really helped with reducing medical error, expediting care, and developing a record across the continuum of care. There have been many different initiatives put on by the national government to increase the amount of technology and implementation of electronic health records. A lot of this came from the Institute of Medicine's report called "To Err is Human" and Crossing the Quality Chasm. This showed how the current record keeping was responsible for a lot of error, and that by using technology, we had a way to get a better handle on that. So one of the early ones was the National Health Information Network that provided standards and policies, ways to connect providers, public health reporting, also the push to give consumers more control of their health information and access to the health record, and more information and better information for clinical decision making. The National eHealth Collaborative, that went a little bit further, looking a lot more on that secure and interoperable health information exchange. So what that means that if you have a record at one particular provider or hospital, that record can be shared with another provider at another hospital or another doctor's office in order to provide care. And then there is an Office of the National Coordinator for Health Information Technology. This was developed when the HITECH Act came, and this supports the development of a health IT infrastructure. And some of you may be familiar with the HIPAA privacy rule. And not only is this rule focused on privacy, but it also protects personal health information and gives patients the ability to access their own information. So I've given a link here if you wanted to get a little bit more information on this, because this is something that's ongoing and active right now. I have provided some information for you to review on James Turley, and he was the nurse that developed the first nursing informatics definition and developed this model. You'll find his interview as a nursing informatics pioneer and his articles very interesting, because you could see this is an early definition, but they have moved since then to look more towards health informatics in the sense that that is nursing as part of informatics, is part of this larger health informatics, and that we are viewing it from a nursing informatics lens. So nursing informatics certification has been around for a long time, and if you're interested, I encourage you to look up the nursing informatics scope and standards of practice and contact me if this is perhaps a career projection you might have in mind. So the nursing informatics definition from James Turley in 1996 is viewing nursing informatics as a specialty area that integrates nursing science, computer science, and information science to manage and communicate the data, information, knowledge, and wisdom in nursing practice. So this is a very short, concise, comprehensive definition, and you could see where nursing informatics falls within that particular Venn diagram. So now we are going to move to examining in some detail the data to wisdom model. Data, information, knowledge, and wisdom. The data to knowledge model includes four main concepts. Data is described as objective, discrete elements and entities. So for example, in nursing practice, data might be a vital sign that stands alone. Or it could even be something like a blood pressure, where the systolic and diastolic stands alone. And you really don't know by just looking at the single number exactly what it means. You move to the next level when you see a set of vital signs. They're placed in context and used for comparison. So this would be if you're looking for a trend, maybe a change in temperature, respirations, blood pressure. So this information, it becomes information that's interpreted, structured, and organized. The next level is knowledge. These are when you develop formal relationships and you synthesize the information. So this is quite often where you bring in your knowledge, your experience, your education to interpret and understand the relationships between the different components, the different information that you've been given. So these examples would be significance of the combination of vital signs combined with other knowledge and experience, often resulting in an action or intervention. So this could be increased respirations, maybe your first sign, and you're looking at the trend, and then you start to think about what does this mean in the big picture of this patient's care. Is this something new? Are they being treated for it? Are they on oxygen? Is it on exertion? That's where the human being would then bring in all that knowledge they have to identify the formal relationships. So wisdom is something that has been defined in a variety of ways and also sometimes discussed in depth in terms of exactly what does it mean. I'm going to use the American Nursing Association definition that wisdom is the appropriate use of knowledge to manage and solve human problems. So example here is a knowledge base may include several options. So maybe you have a situation where this information you've gathered has become knowledge, but now you have to decide how to act. This may be based on your experience. And so this wisdom helps you to decide what is the most appropriate action for that specific patient and or situation. So this diagram shows you the relationship between data, information, knowledge, and wisdom. And you can see that as complexity increases, you will go up the line from data, information, knowledge, and wisdom, as wisdom being the most complex. It's important to recognize that this is not necessarily going to be a linear process, and it's something that's going to be integrated into nursing care. You will be doing this for a lot of information, a lot of data, and making these decisions. So it's a constant flux. And when you first start in nursing, it's quite often that you'll start going through these stages in your mind, pulling this together. You do it in a linear process. As you become more experienced, you move up the novice to expert continuum. You will find that this is something that you're not aware of, and it's actually happening in the background while you're making multiple complex decisions about your patient. Now I will provide a brief overview on applying the knowledge, data, information, knowledge, wisdom model to health information technology. To understand health information technology, it is helpful to understand how the meta concepts of the data, information, knowledge, wisdom model fit in the development and use of different types of technology. So many of you are familiar with information systems such as an electronic health record. And that's basically where they collect data, you chart, and then it pulls it together, and often there's an opportunity to do trends, and you can look at flow charts and different things to see changes across time and look at that. The next step up would be when you take a decision support system and you layer it on top of an electronic medical record. So what that decision support system does is it scans the data and it looks for things like interactions between drugs or appropriate doses based on the patient information. So this decision support system is helping the provider understand and build from information to knowledge. Is that the appropriate medication at the right dose for my patient? And if that patient's on many different complex medications, the decision support system is meant to help with making decisions, not to replace human judgment, but to help you and provide a tool. The next step is an expert system, and these are still being debated a lot and how they can be used, where they would actually have a lot more information, pull together all that information from the electronic record, decision support, and together with some machine learning and predictive analytics that are done in technology, to pull together and actually bring it to a higher level of understanding and recommendation. Some of these are in on electronic health records already in a very minor way. There are some places where that's much more complex. So there might be a scale embedded in the electronic health record that collects the data on a patient's risk of falling. That technology, that system, will then collect it together and give you a fall score. That fall score will give you information to help you apply the knowledge you know about what that means for that patient. Do you need to take extra precautions with that patient? Is this patient able to mobilize? Or do they need help? Are they more likely? Are they on medications if they had a procedure? So then using that knowledge. And so that will then pull together, and the wisdom that's coming in there would be that it would have a little bit more information based on that scale and how it was developed. So it's got that information that was developed by a human pulling it together. This is something that we're seeing more and more, predictive analytics, machine learning, and all sometimes called artificial intelligence. This is something we're seeing more and more in technology in general, and there are some places where it's being applied to healthcare. Now I'm going to provide a little bit of information on information systems. And as I mentioned earlier, this is commonly called an electronic health record, and it usually has a data warehouse associated with it, or what you could call a clinical data repository. It's basically a channel for transmission of patient data. So this particular type of record, it supports multiple functions: practice, research, outcome reporting, organizational measures, and sometimes will even support accounting and billing, such as the use of different ICD-9 or 10 codes. Some important considerations about that electronic record: to avoid having it sit in a silo, and it's a silo of information, we have to have interoperability with other records in other places. We have to have data privacy, we have to have security, it has to be confidential. Accessibility, it has to have access and availability to multiple users when they need it and where they need it. And of course, the information stored there needs to be able to be reused and have longevity, and so it can be reused after the initial appointment. One of the examples of this would be even a baby in the NICU having some sort of a heart surgery. So there they are, a little, baby a week or two old, having heart surgery of some sort. It's not an uncommon procedure. Well, at 10, 9, 15 years of age, there may be a situation where you need to know what surgery was done, what was the procedure. The same can apply to childhood cancer. Later on in life, people may need to know what drugs they were treated with, the radiation, what was done in order to influence their care later. And there are many, many examples of why information along the continuum of care from birth to death is important for real good comprehensive healthcare. So the ability to share data requires interoperability. And interoperability requires technical standards such that the systems, the hardware, the software, and the data can all talk to each other and be connected, and they're designed to work together. This is called harmonized standards. So one of the examples that I like to give is our electrical system. If you go to Europe or somewhere else, you may notice different types of plugs and connectors, and now we have different types of things like USB connectors as well as regular plugs. But when we plug our electronic item in, we are connecting to a huge electrical grid. And without the standards and harmonized standards between the different systems and location, between your home and the electrical power grid, between a business, hospital, the different equipments that are working together, you can run into a lot of issues. And so it's really important that these same standards are developed for health technology or technology in general so that things are interoperable. So one of the biggest issues we have in interoperability today is that in the United States, we do not have a unique health identifier. In 1996, when the HIPAA Act was passed, this was part of it, and it said that the Secretary shall adopt standards providing for a standard unique health identifier for each individual employer, health plan, and healthcare system for use in the healthcare system. In other words, a unique identifier that you would use for healthcare. It was blocked by Congress in 1998, and it is still not implemented. Hospitals use a variety of ways to pull together patient information. They may have their own internal patient identification record, but that's not as helpful in correctly matching patients if it's outside of that particular facility or over time. 8 to 14% of medical records include errors that have to do with the incorrect patient identification. This can have a lot of serious risks. Crucial step in healthcare is to make sure you have the right patient, they're getting the right medication, the right treatment. So this is something that as a society we need to work on and come to terms with. But in the meantime, there's going to be a variety of different ways that entities, different hospitals and them are going to use to communicate among each other using different systems, different matching algorithms, different data dictionaries. So this is something that still needs to be addressed and is still a discussion many, many years later. So now we move forward to look at how the metastructure concepts for health information technology apply to decision support systems. And here you could see that decision support systems, that is a combination of information and knowledge. Decision support systems are based on programmed algorithms. On the next slide, I'll show you an example of an algorithm. But these algorithms are developed by healthcare providers, and they're based on standards of care. They're based on evidence. Medication management, for example, will have an algorithm that will look at the compatibility of the drug with other drugs the patient has taken, patient allergies, prescription guidelines, such as somebody who has issues with their kidney or their kidneys or liver, they're insufficient, so the dosaging may be different. And proteomics and genomics now we're integrating to look at the drug metabolism. How does somebody actually metabolize a certain drug, and do there need to be adjustments made to dosages? It's important to recognize that this technology augments and it does not replace clinical judgment. So this is an example of a triage-based algorithm. This would be if you had people coming into an emergency room, or maybe you had a bunch of people you were trying to determine which one that you would care for first in a triage situation. So consequently, this one has different levels of alert. You could see that if they're able to walk and it's yes, it could be minor. No, if there's spontaneous breathing, yes, you look at the respiratory rate. If no, you're going to go the airway. You're going to obviously do some more immediate intervention. If the respirations are greater than 30, then it's immediate. If it's less than 30, then you're going to look at perfusion. Are the heart beating? Is there a pulse? If it's not, then, if the capillary refill is greater than 2 seconds, then you want to do immediate. And so you go on, and this is an algorithm, and this is something that somebody could actually look at in a chart, but it could also be integrated into an electronic record or a tool that somebody could use even on their smartphone to triage patients in an emergency situation. This is very similar to something that you would have maybe behind the scene for patient falls or skin breakdown. And then depending on the answers to the different questions, there is a response by the system. And in some case, it may be an actual warning or a code and say this person is at a high fall risk or a high risk of skin breakdown. And so this is what's built into the background. And they are developed through evidence-based research providers and the actual experience and knowledge of people. And so once again, these augment your own clinical judgment. So this is another example, and this is real-time clinical surveillance. This is an automated surveillance that's going on in the background of the electronic health record. And based on the information that is being collected, it can generate warnings or make suggestions. And this is often based on clinical performance metrics. There's an automatic quality control that can identify possible errors. There's feedback, so if there's deviation from standards. And again, this is something that could be used in infection, falls, pressure ulcers, public health. These types of things are used to monitor disease and our symptom clusters, like a flu alert. And then this also supports real-time clinical interventions. It could send a notification to the nurse, the pharmacist, or the physician at the point of care that something has changed with this particular patient that you need to go and investigate. So this is an example of a dashboard or a clinical intelligence platform. This particular product was installed in a 23-bed trauma and surgical intensive care unit at Memorial Hermann in Houston. Before they started using this automated approach, the trauma surgeons, the physicians, and nurses would have to compile information from different systems, and that would take 5 to 15 minutes per patient. So with the dashboard, there's a continually protected screen at the bedside so that they can get all the information they need at a glance. It's better time management. One of the physicians mentioned that if you're on call, you need to have this information quickly, say if it's the middle of the night. or a nurse, if you're in charge and you haven't maybe seen that particular patient yet, it's important to be able to get this level of detail in the information. So this is real-time monitoring. It's displayed in the patient room. There is a whole field of informatics that has to do with the screens, the graphical user interface. And so consequently, this one integrates colors that indicate positive or negative trends. Acute events are actually captured for review. So this is really nice because you can actually see the various factors that you're monitoring all at the same time, at maybe the same time as you saw a particular symptom, but you could review them 10 minutes later, an hour later, when a doctor gets there. It enhances teaching, of course, and they're actually working on a variety of mobile versions, and they may have those already at this point. So this is another example of an early warning system, predictive system called the Rothman Index. This one captures 26 different types of patient data and measures data from the EHR. It will run predictive analytics. This is evidence-based analytics. It will display a score of 0 to 100 and a graphing trend for each patient. And the color indicates also which patients that you need to be more alert to. So if you're coming on to shift and you see a patient with a red screen, then you know that might be someone you want to take care of first. While somebody with a green screen or a yellow screen, you may then be able to decide and make your own decisions. It indicates whether a patient is getting better or declining, and it looks for a 40% drop in the last 12 hours for some measurements, maybe a 30% drop in the last 24 for another. And this is an important part of this particular system, and that's that it's not looking for a specific number. The focus is on trends, and it's based on the patient's baseline. And this is really important for chronically ill who may be discharged with a low score. So you're looking at this on a more individual basis. And the implementation team for this is multidisciplinary. You need nursing IT, nursing administration, bedside nurses, palliative care, hospitalists, case managers, bed managers, and clinical champions on each unit to train the colleagues. Next, we will discuss expert systems. This is one of those deep questions. Can we incorporate wisdom and knowledge into health information technology? This would be something that would be required of an expert system. Cognitive computing is the development of computer systems that are modeled after the human brain. So they bring together nanotechnology, neuroscience, supercomputing, and that is cognitive computing. This is still something that people are working on. If you get a chance to look up Watson has been used in a variety of settings to try to make decisions on things like chemotherapy or treatment for somebody with complex cancer based on the current literature, which is extensive, and the particular patient's guidelines. But the amount of information that has to be fed into the system in order to provide that information back is incredible. So this is something that we're still looking at, and whether or not this is something that we can accomplish in health information technology or not is still up in the air. So now let's take a look at the application of technology. So let's start by talking about the application of technology in the neonatal intensive care unit. In this unit, the parents may feel very disconnected. Shortly after birth, the baby is whisked away for medical care. It may be a long time before they can even hold their baby. And then quite often, the mom is discharged long before the baby can go home. And both parents may have to return to work or even live a long distance from the hospital. So the Angel Eye camera system, it's a communication platform for parents of NICU babies. And this diagram shows the camera where the parents can, from a remote setting, can actually see the baby, they can talk with the nurse, they can actually see the baby and how they're doing, which provides a lot of comfort to the parents. So these images show two more devices. One is the camera to look at the baby, and this is when somebody's not holding the baby, and the other one is actually a microphone. This particular system has a variety of features. This is actually the interface that you would see, the parent would see, once they log in to a secure site, so they can actually see their infant, how they're doing. This system also has a virtual rounding capability, and that's that while the doctor is rounding, they can actually use that microphone and talk to the parents and answer questions. And so if the parents can't be on site, they can actually be there. And these are a couple more links to some videos and information on this system. There's more systems like this right now, but this is just one that just takes some basic communication technology and integrates it in. This is also integrated into the electronic health record so that they also have the record in the electronic record of the care of the baby, the rounding, and that type of thing. So falls are a patient safety issue that has been dealt with traditionally through the use of bed or chair alarms and sitters. Telesitters are now available. They're a robot-like device that has cameras and two-way audio capability. They have been deployed in John Peter Smith Hospital in Fort Worth, and they keep an eye on patients that are at risk for things such as falls that are considered never events. They should never happen. In the first 7 months of deployment, falls decreased by 13% with 0 reported injuries. So on your left, that is what you would have in the patient room, and that would be the camera and a two-way audio. And then in the monitoring room, you could see that one technician can monitor multiple patients. They can also talk to the patient. So if they see them getting up or going out of their room, they can actually talk out of their bed. They can actually talk to them and ask them, just, is there something they can help them with? Please wait in bed, reminders, and things like that. Barcode medication administration is another example. The basics of barcode medication administration involve the scanning of a barcode on a medication package, the patient armband, and the ID of the clinical staff giving the medication. The collected data is cross-checked against the database of allergies, dose warnings, and interactions to prevent medication dose errors. At the heart of any medication administration is the 5 rights: the right patient, the right drug, the right dose, the right route, the right time. Most medication errors occur at the point of the physician order or the administration of the drug. So let's have a look at barcode administration workflow to see how this technology attempts to improve medication safety. This example is for the hospital setting with a central pharmacy. The physician places an order for the medication electronically. The medication order is transmitted electronically via an interface engine to a central pharmacy. The pharmacy has an automated system that processes orders and performs the dose packaging of the meds that include a barcode being put on the package. Medications are delivered to med carts on hospital floors, and the nurse or other clinician dispenses the medication. They enter their own ID, they scan the medication, they scan the patient's armband. If the patient is able to, they ask for a verbal identification. It is not unusual for mothers who have babies in the NICU to express milk and then bring it in for their infant. When this was first being done, the bottles were labeled and hand labeled, and then they were administered to the infants. Well, unfortunately, they had some mix-ups, and so one use for barcode administration is also breast milk. And this is because mothers will bring in breast milk that they've expressed for their infants if they're hospitalized or in the NICU. And so at the time that they bring in the milk, there's a system in place that it will be labeled and then stored correctly for administration to the correct infant. Next, we will talk about precision medicine. So precision medicine is an emerging field that takes into account individual differences in people's genes, microbiomes, environments, and lifestyles. I provided here a few links and resources for you if you wanted to learn a little bit more about this. Precision medicine is also called personalized medicine, and it requires all three types of automated systems in order to work. We need the data and information from an information system. We need the decision support, and we also need an expert system to efficiently provide personalized medicine, integrating the concepts of precision medicine. So in order to provide precision medicine, personalized medicine, we need a longitudinal electronic health record. This is to incorporate genomic influences across the healthcare continuum. We have to be able to capture and store data such as test results, treatments, and outcomes throughout the lifetime. And we need to have them available at the point of care. So we know if we're administering medication as nurses that this is an appropriate medication for this particular person based on their genetic makeup. This requires an interoperable infrastructure. Thank you for your attention during this presentation. I hope that you find this overview of some complex health information technology and health informatics information useful as you pursue your nursing career. I'm happy to answer questions. If you're interested in more about informatics, I am more than happy to answer questions, talk to you, and meet with you. I put my email on this slide, and I look forward to further discussion.